Welcome to the HealthLinks podcast, presented by the HealthLinks family of services. I'm your host, DJ Thatcher. Our mission here is to engage in conversations about the medical, health, and wellness landscape of South Carolina so that we're all better informed. In this episode, we're joined by Dr. Chuma Obineme from the Palmetto Primary and Specialty Care Physicians. He is a gastroenterologist, and we'll hear more about that. Dr. Obineme, welcome to the HealthLinks podcast.
Thank you for having me, DJ. Pleasure to be here.
You are part of the network of the Palmetto Primary and Specialty Care Physicians, which really encompasses many of the medical specialties that we see. Of course, you're coming to us from the Division of Gastroenterology. Hey, tell our audience, they probably have an idea of what gastroenterology is, but hey, give us the formal definition of that, if you would.
Our office actually encompasses both gastroenterology and hepatology. So everything from basically your mouth to your anus, and then the liver, pancreas included, really. So we really just deal with all disorders of the digestive tract. I think, when it comes to me and my kind of niche, I'm more on the motility side of things between me and the other two partners in my practice, but that's the overall what we kind of cover.
Now, we have a statewide audience here, and of course, your practices are in the Low Country here. Where are your locations in which you practice?
There's a number within Palmetto Primary Care, but where I practice is mainly, we have a clinic in the Nexton office, and then also at it's right across from Trident Medical Center. Mm-hmm. It's the Medical Arts Building. That's where I have a clinic as well. And then I do my procedures really between Somerville Medical Center and the Charleston Surgical Center. What is nice is that we're doing this interview, I think perhaps 2 weeks before our new ambulatory surgical center opens in Nexton. Yes. It's the Nexton Procedure Center, brand spanking new, gonna have 3 endoscopy rooms. It's gonna be humming. So it's really exciting. We're gonna offer another site for our patients to get procedures done.
That Nexton area is growing tremendously, and yet it's such a convenient location, especially for people who are coming from other areas of the state, coming into the Low Country, and of course for those who live here as well. So good for you. Yeah, beautiful area. Yeah. So you mentioned a moment ago about procedures, and I guess when we think of GI, gastroenterology, and so forth, people are thinking about the colonoscopy, but there's a whole lot more that you do. And give us an idea of some of the procedures you specialize in.
As I've been doing procedures and stuff, I've been getting a lot of questions about what would make you go into gastroenterology. And I really fell into GI more from the esophagus perspective. Some of my early mentors who really kind of taught me the ropes of GI were one was actually a hepatologist at Maryland, and then the other was Dr. Anand Jain. He showed up at Emory during the end of my residency, and we started doing research together. And it was a really great relationship for the 4 years that we were kind of working together. So sure. Procedure-wise, yeah, I do the normal colonoscopy stuff, which I'm sure people are familiar with, but I also do upper endoscopies, which is placing a scope into your mouth and then going into the esophagus, stomach, small bowel, but also really some complex, esophageal, dilations for patients who have difficulty swallowing. When it comes to motility, some of the other procedures are really, we call them manometry-based procedures. Really, these are procedures that use pressure sensors to really understand different organs, specifically the esophagus and the rectum, and better understand how they function. When it comes to GERD, reflux testing, we do a little more in-depth reflux testing, and then we do some more complex dilations in patients who have difficulty swallowing too.
You're really affecting people with the quality of life, aren't you? Either and that you're talking about, some of these conditions that people have, it really does affect their everyday living, doesn't it?
These are symptoms that they've been living with for a very long time, but don't want to really talk to anyone about, or just they've been finding their own ways to get by with these diseases. I just diagnosed a gentleman with, eosinophilic esophagitis, which is kind of like an allergic kind of inflammatory condition of the esophagus, where over time, because of the development of, inflammatory cells, the esophagus essentially becomes scarred and fibrosed and doesn't work anymore. But these guys will come in and they'll say, "Oh yeah, I always, am the last one, like first one at the table, last one to leave, grind up my food, 30, 45 minutes after everyone's left, and just hoping and praying that food doesn't get stuck, or I don't have to go to the bathroom and then bring it back up in order just to be able to get through my meal."
Sure.
It's always surprising me, like what, great lengths we go through to kind of compensate for some of the issues we're having.
Expand for a moment, if you will, some of the signs or symptoms that people might be just living with. They're putting up with it. Maybe they don't even realize that there is a treatment or a cure for some of the things they're dealing with. What do you see primarily?
Yeah. I think, when it comes to the esophagus, the most common things are difficulty swallowing, so any time that a patient tells me, they have difficulty with large pills or difficulty with solid foods, or even, a really good concern when people tell me they have difficulty with liquids, that's really a concerning symptom. But, whenever someone tells me that, they eat food and they have to do some kind of maneuver in order to get it down, or, the apprehension around eating certain foods like steak, chicken, pork, or even breads that get really dry, those are some of the common things that people will tell me. It's also interesting too, for, a lot of people think that the esophagus is just for, swallowing food. But it's also actually really important for the clearance of acid. So a lot of what people will tell me too is like they think they have reflux, which is classically like burning behind their, sternal bone, or feeling like food wants to come back up. And they feel like these reflux symptoms are worsening all of a sudden, or they're not really responding to their typical Tums or over-the-counter medications. And actually, the esophagus is really important for, clearing the esophagus from its acid, because if you can't clear acid from the esophagus, the acid sits there, it can actually continually damage the esophagus and then lead to all sorts of other problems, whether that's worsening difficulty swallowing or even, precancerous.
Yeah, a lot of people have, like you said, have that burning in the chest and so forth, and probably the first thing they think of, hey, am I having a heart attack? I guess the symptoms are very similar, and yet obviously the treatments are drastically different. So someone who's experiencing that type of thing, can they refer themselves directly to your practice? Do they have to go through a primary care physician otherwise, or how does that work?
I think the vast majority of the patients that we see do come by way of their primary care doctor, just because sometimes it's, their PCP has started anti-reflux therapies and, either it didn't work at all, or maybe it worked a little bit in the beginning, but now it's starting to really, get out of hand. Or I see patients who, have been self-referred, because, they've been dealing with this issue for a while, and, they really, they've either, read about me, read about the condition, or both, and, really want to have a better understanding of, what is actually going on. I think, especially with the esophagus, I've seen that a lot is that, I think patients, while they want to feel better, I think a lot of them have a desire to really understand, what's actually happening to them, because they know that what's happening to them is abnormal, and it shouldn't be that way.
Prioritize your health with a subscription to HealthLinks magazine. Get every issue of HealthLinks delivered right to your door for only $15.99 a year. 6 issues packed full of local factual health information to help you be the best version of yourself in 2024. Subscribe now to HealthLinks magazine. Visit subscribehealthlinks.com. That's subscribehealthlinks.com. HealthLinks magazine, the Low Country's prescription for well-being. You're watching the HealthLinks podcast.
Now, of course, you're a gastroenterologist. You specialize in the gastrointestinal side, but you also mentioned the hepatic or liver side as well. And 2 questions. One is it common for people in your specialty to be a specialist in both? And secondly, especially for our lay public, what is the relationship between the liver and the GI tract?
Most people who go through gastroenterology fellowship training are going to be trained in both. There is, more advanced training if you want to be, credentialed in transplantation, like liver transplantation that you need to go through. But all gastroenterologists have a really good foundational understanding of the liver and kind of the diseases that affect it. I think in most cases, I think of them as separate, but there is overlap between, diseases of the liver and diseases of the GI tract. Usually when we think about liver disease, of what we're seeing, I think the major thing we're seeing is really fatty liver disease, which is really a burgeoning health crisis, to be honest. Fatty liver has now kind of, the nomenclature has changed a little bit because we've tried to really drill down fatty liver that's perhaps from alcohol and then that fatty liver that could be related more to lifestyle factors like hypertension, heart disease. So now it's really called metabolic associated dysfunction, steatosis of the liver. It has kind of evolved in that nature. There's a number of diseases that kind of cross over in both.
We have our challenges in South Carolina. It's a beautiful place to live. We love it here. From a medical standpoint, we've got a lot of diseases. We top the list or near the top of the list across the country. And what are you seeing? Now, I know you've trained in other areas. You're relatively new to South Carolina. What are you seeing here? Differences in just the population or the diseases that you're seeing between South Carolina and other areas where you've practiced?
I think here, I think there's definitely, when it comes to, I think fatty liver disease is major, especially, because it has, this relationship with hypertension, type 2 diabetes, hyperlipidemia. Sure. So that's really been a major one. I will say that the nice thing about the practice is that in addition to kind of the standard ways that we evaluate patients with fatty liver disease, we also use something called a fibroscan. So it's really a non-invasive test that can really determine if someone's, liver disease is really due to fatty liver or if it's due to something else. And I mention that only because, a lot of times, while it is very common, I think sometimes people will get labeled with fatty liver before having like the full workup for it. Seen a lot of that. I have seen more EOE, more eosinophilic esophagitis. I think definitely that I saw in Atlanta. I want to say colon cancer too. I mean, it has been really, shocking to me, the number of patients who, have had, chronic, abdominal issues, whether it be abdominal pain or even, a lady with diarrhea, who are found to have, colon cancer. And it'll be, an individual who this is their first, screening exam in their mid 60s. Those have been the most, frequented and disorders that have surprised me.
And besides alcohol use, what else can people do to help both their liver and their GI tract just to stay healthy?
I think when it comes to the liver, I think the most important thing in patients who are doing well, is to really think about the risk benefits of doing anything. We know like keeping a balanced diet. I think there's been a lot of research around the Mediterranean diet when it comes to, limiting the amount of fat deposition in the liver, weight reduction in cases, physical exercise, all those things I think are great. I'm always, hesitant to tell patients about like adding necessarily supplements only because some of those are quite unregulated, and it's hard to know exactly what's in them, what's not. Now, in my patients who do have fatty liver disease, where we know there's significant fat deposition, and that fat deposition, over time is going to lead to liver scar and cirrhosis, I think it is prudent to be a little more hands-on with the approach. So I think in those cases, we know if you lose 7 to 10% of your body fat and you have steatosis in the liver that's, due to fat, you can actually completely reverse the excess fat that's in the liver and then some of the inflammation that may come as a result of it. There's also been studies around, coffee consumption when they compared individuals who drank around 4 to 5 cups of coffee versus those who didn't. Those who drank coffee actually had less fibrosis in their liver than those who didn't.
It's a debate in our house. I'm not a coffee drinker. Can't even stand the smell of it. My wife loves it, so it'll be ammunition for her. Yeah.
Right, exactly. There's a couple different medications that we always get concerned about. I mean, Tylenol is great, for when you have pain and, aches and things like that, headaches. Taking any more than 4 grams within a 24-hour period can certainly lead to damage of the liver, which we don't want. And then in those folks, who once their liver disease may start progressing, we also think about ibuprofen and any NSAIDs, not for the damage to the liver, but actually for the damage to the kidneys. There are some new drugs in the pipeline that, people are starting to prescribe for fatty liver. But I guess I'm kind of waiting to see a little more data on some of these.
Well, thank you for the advice. Great advice. One of the big elephants in the room, of course, is the recommendations for colonoscopies. I imagine that's why a lot of people hesitate in maybe getting a consult because of everything, regarding that, the prep and the procedure and so forth.
Yeah.
Critics would say, hey, why is that necessary every few years if the medical community doesn't recommend a full body CAT scan every few years to find a tumor or a cardiac catheterization to see if there's any heart disease? Where did the recommendations come from? And first of all, what are the recommendations today? And also, what other alternatives are there with the Cologuard and maybe some of the blood tests and other innovative approaches?
Yeah. In 2021, the American College of Gastroenterology put out basically new recommendations for colon cancer screening. They dropped the age from 50 to 45. That was primarily because while, we actually have in the last few decades seen the mortality rate from colon cancer in older folks go down, we've actually seen the prevalence of colon cancer in patients younger than 50 actually go up.
By the way, where is that right now as far as the leading cancers? Is that second, third? I can't recall.
Yeah, it is. I want to say it's the 4th leading diagnosed, but then it's the 2nd leading cause of death.
Oh, wow. Okay.
Yeah. When it comes to for cancers. Yeah. So we've seen it go up in younger individuals. So that's why they decreased basically when they'd start screening from 50 to 45. The other big question everyone's asking is what is leading to the increase in colon cancer among that younger age? I don't even say it's $1 million question. It's probably $1 billion question. Okay. We think it's, lifestyle things as, the increasing risk of obesity, Western diet, lifestyle changes, sedentary lifestyle. We think that's what it's caused by, but we're not exactly sure. The big question is, why colonoscopy over the other ones? And then what are the other options? I think I'll just give you an overview, of the options. Okay. So
sure.
Colonoscopy we have, which is really, you're talking to a gastroenterologist. So I say it's the gold standard.
Right.
Because it's the only test where you can look and treat exactly what you see. And hopefully remove polyps that are eventually going to turn into cancer as opposed to finding cancer. So I'll say there's colonoscopy. There's the stool-based tests in that you really have FIT and Cologuard. So the way to think about FIT and Cologuard is FIT really is kind of, a test wasn't really developed for colon cancer screening because really what it does is that you give a sample and it looks for essentially blood and then some abnormal DNA in your stool. Cologuard does the same. They just look for more different kinds of DNA changes in your stool. There's also ColoSense, which is similar again, but instead of looking for DNA abnormalities, they're looking for RNA abnormalities. These are all just different kinds of genetic material that, becomes aberrant and dysregulated in folks who have colon cancer. So those are all the stool-based tests. And then there are a couple blood tests that have come out. One of them is Septin9. It's methylated DNA fragments that are in the blood that are, that become more prevalent in patients who have colon cancer. And then there's the cell-free DNA testing, which is kind of the hot new kid on the block. It's really cell-free material that they find in the blood that's more prevalent in folks who have colon cancer.
It sounds like the blood-based and the stool-based test. It almost sounds like, maybe I'm wrong, that by the time you see something abnormal in those, you probably have some pathology going on versus the colonoscopy with a trained eye like yours. You're picking up problems before they become a pathology. Is that a fair statement? I don't know.
When you think about all the stool-based tests that we talked about, FIT, Cologuard, ColoSense, these are pretty good tests when it comes to finding cancer. If you're going about on average, you're probably looking at maybe like a 75 to 85% sensitivity, i.e., what's the chance if I had a positive test, me actually having colon cancer? It's a pretty good test when it comes to colon cancer, finding colon cancer. But I really want to know not just if it's good at finding colon cancer, but is it good at finding these like advanced adenomas? An advanced adenoma is really, it's a polyp that is showing signs, of having these precancerous, this change from really a polyp to cancer already in it. Because that's really the point where if we're able to do your colonoscopy at that point, remove this polyp, then, we've really stopped, the whole cancer tumor genesis pathway. How do those perform with advanced adenomas? They're usually in the low, maybe about 40%, 42%, worse than a flip of a coin. They're not really good as if you think about them in the context of like, I think preventing cancers. The stool blood tests, so far as, I don't know if I'm a little fuzzy on some of the numbers. I know for the cell-free DNA, which I believe is commercially available as the Guardant, I want to say when it comes to finding colon cancer sensitivity, I think it's in like the high 80s.
Okay.
I want to say like 80s, 90s. So pretty good at finding colon cancer. When it comes to advanced adenoma, 13% was the number that I remember. Yeah. So not really good at finding, advanced lesions that you really want to take out before they become cancer. And the other thing just to note, I think in clinic I've seen, because I want to say a lot of these blood tests are just becoming commercially available. And I'd have to look and see if, the United States, Preventative Task Force is actually given the green light on them before, because that's really what determines whether or not your insurance company is actually going to pay for the test that you got sent for. When it comes to the stool test that more folks, come to me, I see a lot of positive Cologuards. We know, right, that if you wait longer than 6 to 9 months after you've had a positive stool test, if we do find a lesion, or it is going to be more advanced than if you would come sooner. It is really, really important that if you do have a positive test, not as a way to scare folks, but as a way to be prudent, that you really have to start making the steps to get a colonoscopy as soon as you can. And the other thing, these tests they're only for specific patients. The two main things you have to know is that, you really shouldn't be getting these non-invasive tests if you have a family history of, colon cancer, and 2, if you have symptoms, right? If you have belly pains or abnormal bowel habits or character, or the texture of your stool has changed, or, you see intermittently you have a little bit of blood in your stool. I mean, these are really not appropriate tests to be using in these kinds of patients.
Well, thank you for this really in-depth overview, going deep in the woods, deep in whatever. But no, it's something that's really necessary. A lot of people are questioning, hey, why should I do this? It's a big ask, but by the same token, it sounds like there's a big benefit. Obviously, you're well trained. University of Maryland undergrad, right? Or a medical school, undergrad and medical school. Then Emory University for your residency and fellowship. Give the audience an idea of how long is that whole training as far as after med school, the residency and fellowship for what you do.
Med school, 4 years, and then residency you do 3 years. Really it's your intern year for 1 year, and then you're really kind of managing teams for your next 2. And then fellowship is 3 years. that's the base right there. Because you can certainly do programs for advanced positions that'll add an extra year to 2 years.
It's interesting too, looking at the other side, or the personal side of folks. I know your background, a lot of cool things come up when you look at you on social media. One is salsa dancer. Still doing that, or what was that all about?
Yeah. I definitely do try to do that a little bit. When I was an undergrad, a couple of my friends kind of just picked it up. One of them was Puerto Rican, and we just ended up joining the salsa team when I was in undergrad, and I kind of just kept doing it, even when I was in med school, at Emory. There's actually a really great community. And what's been nice is, going abroad and getting to dance, the culture is, it's a different thing, dancing. My older brother lives in Medellin, Colombia. Dancing there was incredible. The energy, it's fire.
One other thing that caught my eye too, it says here, retired fencing. Now that's not like fence posts and building fences. That's the actual fencing, right? How did you get into that? Or you retired from that now?
I played football when I was in high school, and going to a D1, institution. I decided just to skip tryouts because I didn't think it'd be for me.
Wow.
But I had loved the movie Pirates of the Caribbean, and so I always was interested in sword play. Yeah, I ended up joining University of Maryland's fencing team.
Man,
I did fencing for probably the first 3 years that we were there. So it was actually a ton of fun. My coach, Dave Griffin, he actually was in the Olympics way back when. So he was just way more intense than I had expected. The whole bit to be. So yeah, it was a lot of fun.
Who knew that Johnny Depp in Pirates of the Caribbean could inspire a D1 sports career? That's cool.
Yeah, no, it was a blast.
Well, I know you have a background in podcasting as well, and it certainly shows here. We appreciate you joining us. And again, it is Palmetto Primary and Specialty Care Physicians. In this case, a division of gastroenterology. So, Dr. Chuma Obineme, thank you so much for joining us here on the HealthLinks podcast.
DJ, thank you for having me. I appreciate it.
And folks, remember our podcasts do have a video component as well, so make sure you tune into that and watch images and pictures that we might have there. And also, love to hear from you. Reach out with any thoughts you have on any of our guests, or perhaps suggestions for future podcasts. You can reach out directly to me at host@healthlinkssc.com, and we'll put that down below here as well. So once again, DJ Thatcher, thank you for joining us here on the HealthLinks podcast.